President Cyril Ramaphosa says the signing of the National Health Insurance into law is a pivotal moment in the country's history. This is despite criticism by some opposition parties, health practitioners and business groups who've threatened to legally challenge the scheme. Ramaphosa says the NHI will go a long way to reverse healthcare inequality.
This transformational healthcare initiative in many ways gives further impetus and effect to our constitutional commitment to progressively realize access to healthcare services for all its citizens. In its essence, the National Health Insurance is a commitment to eradicate the stark inequalities that have long determined who receives in our country, who receives adequate health care, and who suffers from neglect. By putting in place a system that ensures equal access to health care, regardless of a person's social and economic standing and circumstances, the NHI takes a bold step and a stride towards a society where no individual must bear an untenable financial burden while seeking medical attention. Now, addressing this imbalance requires a radical reimagining of resource allocation and a steadfast commitment to universal health care, a commitment we made to the United Nations. And let it be clear that universal health care is a global initiative in many ways, where a number of countries are moving towards universal health care, and we as a country have made a global commitment that we are going to have universal health care.
Well, let's discuss more around the NHI Bill, which effectively is law from today. And we're joined by the President's Health Policy Advisor, Professor Olive Shisana, who joins us via the virtual platform. Professor, good evening to you, and thank you very much for your time. It must have been a very exciting moment for you today, watching the fruits of your work as an advisor to the President on health matters. Talk to us about that first. How did that feel today?
Well, I must say that after 30 years of working on this national health insurance with a team of dedicated people, it was such an exciting moment. It was actually unbelievable that 30 years has gone while we're busy debating, discussing, sharing ideas with a range of people about the kind of healthcare system that we should have and how we should be financing this healthcare system. So it was exciting.
Yeah.
Really. Exhilarating, actually. Let me put it that way.
We're going to come back on the financing element because it is what has gotten at least the people in the private healthcare space really worried. Let's talk about the looming legal challenges first, Professor. One of the people that you, sorry to cut in there. One of the people that you worked with during the COVID period, Professor Salim Abdul Karim, is of the view that actually challenging this law, because that's what it is now, taking it to court, and ultimately, I guess, it is going to land up at the Constitutional Court, is probably one of the best things to do because it has to, at the end of the day, pass legal muster. Do you agree with his sentiment?
Let me say that as far as we're concerned, this act, which has just been passed today, will pass the constitutional muster because it was drafted by a constitutional lawyer. So we were always concerned about the law being very much in line with the Constitution. That's why Section 27 of the Bill of Rights in our Constitution guided the development of the legislation. So it's fine. I think it's people are entitled to take any law and take it to the Constitutional Court. And of course, we are confident that the bill that has been passed into law is constitutional. There's nothing unconstitutional about it. If there are any errors, whatever, of course, the Constitutional Court will find it. But as far as we're concerned, in drafting the law, it was drafted with the Constitution in mind.
Yeah. Some of the people I spoke to last night were saying that part of the reason it may not pass constitutional muster is because some groups are excluded, and they made mention of foreign nationals. They also made mention of pregnant mothers. Do you want to just deal with those quickly before we move along?
I'm not convinced that pregnant mothers are not included in the bill. The bill is very clear that it includes them. The foreigners, it depends on which foreigners you're talking about. Because if you talk about the refugees, they are going to be included. If you talk about people that are foreigners who do not have any IDs and so forth, there are ways of being able to get them to get services, even if they don't have IDs, particularly if we're going to be using fingerprint technology to be able to identify people. The government will be able to identify those people and make sure that they do get access to healthcare.
So let's deal with the scaremongering. What do you think is the source of that in the main?
It's all about resource distribution. If you have allocated resources in such a way that it benefits a few people, those few people are going to fight tooth and nail to make sure that those resources stay with them, even if the majority of people are not allowed to have access to those resources. So it's all about the balance of resources, between the haves and the have-nots. The have-nots are the majority who are using public sector services. The haves are the ones that are using private healthcare because they've got medical aid, and they are wanting to hold on to their own healthcare, their own doctors, their own nurses, their own everything, even if it means that the majority of the people do not have to share the few that are remaining. So that is the battle that we're dealing with here. It's a battle of inequality. We're saying, how can we ensure that with national health insurance, we end this inequality and bring everybody together so that we are socially a cohesive country, like many people do all over the world?
Professor Shisana, there is this view that funding this national health insurance is going to be a mountain to climb, and 300 billion is the amount mentioned per year. Is the fiscus healthy enough to support the implementation of this law?
There's a general tendency of people thinking that when you say you are starting national health insurance, you are starting from a zero base, that you're going to need 300 billion rand that's new, that has never been on the table. What they're forgetting is that we already have more than 250 billion that is currently providing services. And that money is going to become part and parcel of the national health insurance. So the additional amount that's required will have to be found from some of the money that the state is actually supporting the private sector. For example, about 70 billion rand of the government resources are financing people who have got medical aid. And
How
where
so?
do they get that money? That money comes in from the taxpayer. So the state is taking the taxpayers' money and supporting a few people who have got medical aid in the private sector. So if you add that 70 billion and you add the other amount, 250 billion, you have enough to be able to start phasing in NHI. You're not going to be able to get NHI, all of it running, say, day one, but you're going to phase it in a very systematic and responsible way, fiscally responsible way, to ensure that national health insurance can be able to be rolled out in the country.
Explain this 70 billion rand that is benefiting those who are on medical aids. How does that come about?
Take, if I was working for government as a government employee, not as a consultant of an advisor, but I would have to pay a certain amount for medical aid and the state would pay the other amount. The combination of those is what I would be paying towards the medical schemes. Now, if you count how many of the employees of the state are on medical aid, and you count how much they're actually contributing, and you take away what they contribute and leave what the state contributes, you get that 70 billion.
So
it was calculated by the Council of Medical Schemes, actually. Mm-hmm.
Wow, that's very interesting. So if then this amount of 300 billion is going to ultimately be available, what are the mechanisms that are there that are going to make it be available? Yes, you mentioned that already the healthcare space is funded, but I guess it's about how you use those finances. As you say, NHI is going to be phased in. That amount of 300 billion is ultimately what needs to be available each year in order to phase in this national health insurance.
You want to know how it is going to be allocated?
Indeed.
You know, what we're dealing with here is a question of misallocation of resources. South Africa has got adequate resources to be able to provide healthcare to everyone. We spent about 8.5% of the GDP to provide healthcare in the country. That's much more than many other countries that have implemented national health insurance type of services. So what it is we need to do is to look at what we have at national level, what we have at provincial level, which we are sending from the national to the provinces, and then look at the amounts that the state is paying to the private sector medical schemes. And then you also look at the tax credits that the government is actually giving, you know, to those that have got medical aid. In a sense, what they are doing is, in Shangana, I would say that uteka saba uchelangwenya. In other words, you are taking sand and you are going to throw it on the crocodile. So the crocodile has got plenty of soil and yet you still go of sand and yet you still go and give it to them. So if you start combining all of those resources into a national health insurance fund, that fund would then be able to reallocate resources to those providers in the public and private. In other words, people will be able to use both the public and the private sector funded by the NHI fund. So there will be a kitty of money that would actually be made available to purchase services for the entire population from the public and the private sector. So we're going to be using the private sector as well as the public sector in delivering services under NHI.
And that is the source of the worry, Professor Shisana, because you use the word misallocation of funds. Those that are critics of the NHI are saying that this is the mismanagement, misuse, misgovernance of public funds. And that is why the public healthcare system is where it is. I listened to one expert this afternoon being interviewed on this station, and they were saying essentially what is a big source of worry is paying more to achieve the worst outcomes. That is the biggest elephant in the room, is it not?
No. Let's understand what we mean by misallocation. Misallocation can be done through a policy. Rina Venter, of the last apartheid minister of health, created this problem we're having that we're trying to resolve. She misallocated resources by setting up private healthcare system the way she did it. She set it up by taking public resources and gave it to the medical schemes so that they can be able to establish a private healthcare. She put a lot of resources to create a private healthcare system, which was not as strong as it was, before 1994. Consequently, you have a situation where the bulk of the funds are serving 14% of the population. The rest of the population is supposed to be using the small amount of money. That is what I'm talking about when I say misallocation of resources. So let's understand the terminology, because if we understand the terminology, we'll be able to communicate together. Otherwise, we just keep throwing things out there to say, oh, this is terrible, this government is not doing the things correctly. No, it's about policy change. And that's why the National Health Insurance has been devised to try to correct these imbalances in the allocation of resources, which were created, by the previous administration of the apartheid government.
Someone said today, Professor, that this is arguably the biggest state enterprise ever created, because you have huge sums of money that are going to be targeted at the national health insurance. But the biggest worry is the trust deficit, because people go to public hospitals and they get the worst outcomes. Yes, I know we have been talking government down, but if genuinely this is going to help the rest of South Africa, why would the Public Service Association, or Public Servants rather, Public Servants Association, who spoke on this channel this afternoon, were saying that no, their members want to keep their medical aids. They do not want to be part of this national health insurance. I'm not making this up. I'm hoping that the team has at least cut that soundbite. The PSA, we're on this channel. They represent a good chunk of government workers. If government workers are skeptical about a scheme that is created by government, why should people who have medical aids trust it?
Let me say that as far as I'm concerned, the Public Servants Association are only one group of unions in the country. We've got many other groups of unions which are represented, for example, by COSATU. COSATU has been supporting the national health insurance, and they represent workers. So I cannot say just because the Public Servants Association say that they don't want their members to join the national health insurance, that they should keep things the way they are. Therefore, you know, everything is quite bad, because that is what they are saying. But the other thing that I want to say is that, you know, the notion that the entire public health system is bad, it's wrong. Evidence doesn't show that. If we are serious about understanding the situation in our country, we have to be evidence-based. We have to look at the outcomes, the health outcomes in the country, and judge them. We have to look at the quality of services. If I look at data that we have, more than 81% of South Africans who are using the public health sector are happy with the public health sector. They are happy with the services that they are actually receiving. So when we start saying that the public sector is bad and therefore don't spend a whole lot of this money, keep these inequalities where the few have got more money, you know, from the taxpayer, and the majority of the people have to continue, they're saying they have to continue getting poor health care. No, we're saying every South African must be able to get the same level of good quality health care. And that is what the NHI is going to do. That's why it has accreditation of services that are going to be provided. In other words, the service providers are supposed to be accredited, both in the public and private sector. This is an innovation because we've never introduced accreditation in both the public and private sector to meet the same good quality standards. I think people should be very excited that this government is really taking it serious to really raise the level of healthcare in the country.
Professor Shisana, I cannot argue with that, because ultimately this is about helping the rest of South Africa, particularly those who cannot access quality health care. And perhaps now that you've brought up that point, so let's go there. You have seen countless reports from the health ombud, at least the one who has recently retired, Professor Malekapuru Makgoba. The things that are said in those reports about the public healthcare system, I hear you when you say 81% of the people who are using the public healthcare system are happy. But what do we do with the rest that clearly gets the biggest attention from people like myself, media practitioners, because that is what is scaring people? How do you improve quality health care in a system where the workers are completely demotivated? And I'm using an example of a gentleman who sat exactly where I'm sitting now yesterday, who says, we refuse to be accessories to murder.
I think that's an exaggeration when people say they're accessories to murder. There is no conscious effort of people who say that they're just going to kill people when they come into the healthcare system. That doesn't happen. Let me say to you that the South African government has introduced a national quality improvement plan, and that was introduced as early as 2019, where they are taking a group of facilities that includes the public and private, and let them participate in a quality learning center where they learn how to introduce quality standards of healthcare, where they learn to identify high-risk cases so that they can be able to refer them within the area where the services are being provided. I'm very pleased to say that the performance of those facilities in terms of quality healthcare has improved to about 85% in those areas. So my view is that the National Quality Improvement Plan, which is being implemented in the learning centers in all of the provinces and being done together with the University of Alabama in Birmingham, where they are actually training our leaders in healthcare to be able to provide good quality healthcare. That is a good example of really taking the concerns of the public into account and saying, let us improve the system so that people can be able to get excellent quality of healthcare, regardless of whether they are wealthy or they are poor, whether they use the public sector or the private sector, they should still be able to get good quality healthcare. And I think that at some point, the media must be able to go to some of those places and begin to look at even those that are doing well. To focus on those that are not doing well, it's not really appropriate. You have to focus on everything to be able to have a better sense of what the situation is. We can't look at the extremes only, of the very best and the very worst, but you have to be able to look across to be able to figure out exactly how the healthcare system is functioning.
Before I take a break, whilst we are on the subject of improving the outcomes of healthcare, we know that phase 1 had to do with the pilot projects, and the view, both from those that are observers, are saying that these pilots, they did not actually succeed. They failed. I was hesitant to go to the Democratic Alliance because the opposition, what they do best is to point out the wrongs and harp on those, leaving out the good elements that you are talking about. But I'm hoping that you can point us at least to the good parts or the successes that you talk about. The DA says all of the pilot projects have failed of this NHI. So why in the world should South Africans be hopeful here? Are they right?
Let me tell you, you know, the pilots were pilots by nature. The pilots is testing out various aspects. They never tested NHI, by the way. NHI can only be tested as a comprehensive system. And the pilots were never a comprehensive system like NHI is going to be. In fact, so much has been learned from the pilots that it influenced the development of the National Quality Improvement Plan. So I would say to them that they shouldn't be concentrating on some of the failures that may have occurred during the pilot, because we learn from the failures. You don't learn only from the successes. You also learn from the failures. So you take those lessons, you integrate them into a new plan, and that new plan has now produced improvement in the quality of health services as perceived by the people that are using the services. Many of the people that are criticizing the public sector do not even use the public sector. They don't even know. In fact, some of them were actually shocked during the COVID period when they were supposed to go and get vaccinations. They were like, what? Does that mean that we can go in there in a clean place and then you get very quickly, you are treated and you leave? They were shocked. They had never seen that, because the narrative that has been created in South Africa is that the public sector is a bad place to go for healthcare. Not all of the places. There are some that are bad. In fact, even in the private sector, there are some that are very bad. Go to some of the GP offices that are being run here. Go there, and you'll see that there is a need for including them in the quality improvement plan. That's why we've included the GPs in the National Quality Improvement Plan and make sure they are part of the learning centers where they can be able to improve delivery of services.
Yeah. Let's take a pause there, Professor Shisana, because when we come back, I'd like for us to talk about the management at public healthcare institutions. By the way, we are going to have a conversation around the private sector because they should not be left out. Some strong statements were made on this channel last night about private healthcare and where it is. So let's take a break. When we continue, we'll pick up on those. You're watching News at Prime. If you're just joining us, we are in the middle of a conversation about the national health insurance that was signed into law today by the president. But there are those who are saying that this is not the way to go, and they plan to take this to the highest court in the land. Let's continue the conversation with Professor Olive Shisana. She is the special advisor to the president on health matters. Professor Shisana, let's talk about management at public health care institutions. I'm not going to personalize it, but there is one particular case study I'd like to talk about. But before we get there, talk to us about your assessment of management at public hospitals. Are you satisfied with the level of management there?
Let me first of all talk about the environment within which the managers are working in the public sector, and also compare them to the management within the private healthcare system. Managers in the public sector have got a very heavy load of patients. There is overcrowding in the public sector, mainly because the doctors that are supposed to be in the public sector have been absorbed in the private sector because of higher pay in the private sector. The private sector has got very few patients compared to the public sector. If you walk to any of the private sector facilities, you won't find them being so overcrowded. You'll find many of them having space for people to sit, space to stand, space to do whatever services that they need to get. They've got a lot of equipment. They've got fewer people that are actually using those equipment. The public sector managers are struggling because with the few equipment that they have to serve a whole lot of people. So we cannot sit here and blame the public sector managers and say they're just not good. The environment within which they work, it's a difficult environment, and hence there is a need for national health insurance to be able to share the resources between the public and private. And you share those by making sure that the financial resources are put under an NHI fund as a single payer to be able to distribute the resources properly. And if you distribute those financial resources, you'll be able to purchase the equipment in both the public and private, and make sure that both of them have got services for those that decide to become part and parcel of the national health insurance in the private sector.
Yeah.
So I would not want to look at cases, this and that and that. There are many cases. You can go to the private sector, you'll find some cases. You can go to the public sector, you will find some cases.
Yeah.
Some of them don't even get studied in the private sector because we never put a spotlight on the private sector. We put a spotlight on the public sector because it's money that's coming in from the taxpayer.
And Dr. Mkabayi, I think you and I will agree that as a private healthcare user, I'm now using myself as an example. If I complain about a bad service at a hospital, private healthcare institution, I will be taken seriously to a point where, in all probability, it could go as far up as the CEO's office, where it will be entertained. But the problem in the public healthcare institution is that I doubt that people even have access to someone who can point them in the right direction as to where complaints are filed. But be that as it may, there is one case study I'd like us to talk about, because this is what raises concerns about public healthcare institutions. Rahima Musa, Mother and Child Hospital, a former CEO there, had to be removed because she simply sat at home 182 days. I'm not going to mention her name, although her name is out there. So she clearly was ineffective as a leader. The nurses that filed a complaint about the situation in the neonatal care, 55 grievances by her staff against her. Ask me where she finds herself today. The understanding is that she has been shifted to the health department in Gauteng. Why would a person like that still remain in government or in the employ of government if government is genuinely serious about shaping up its image?
The Rahima Musa case cannot be generalized to the whole health workers in this country. It can't be. It's a bad case, but it cannot be generalized to the whole healthcare system. And I think this is what I'm trying to say, that we need to work towards getting a balance in our evaluation of situations. South Africans, we tend to have extreme approaches to anything. When you take something, you see this is a problem, you suddenly think that the whole situation in the country is like that. There are many, many excellent facilities, like, for example, the Mamelodi Day Hospital. No one says anything about the improvements at the Mamelodi Day Hospital after the horrible incident that occurred there, where patients were sleeping under the desk, under the chairs. Have anyone bothered to go there to see what has happened? Why has Mamelodi Day Hospital improved so much that people would just love to go there?
All right. Let's move on to the private healthcare sector. I was talking to a medical doctor last night, Dr. Brian Ruff, and he says that there is serious mismanagement of resources in the private healthcare space, and that if you're going to sort out the public healthcare space, you've got to start with the private healthcare space, because that's where resources are concentrated for a few, when in actual fact, we should be looking after the entire country. Basically, it's not sustainable, the direction where the private healthcare space is right now. I take it you would agree with his point.
I would agree with Brian Ruff, because what he does, it's really excellent. He is doing evidence-based medicine. He's actually evaluating whether the resources that are being put in there, are they purchasing the services in a way that would lead to better health outcomes or not. He's looking at the inputs, the use, and the outcomes, the health outcomes. And that's what we need in this country. Those are the kind of people that we need in the national health insurance system to come in and assist in working towards strategic purchasing. That is what's in the National Health Insurance Act. It talks about strategic purchasing, purchasing services for the population that are going to have a maximum impact in terms of improvement of the healthcare, of the health outcomes. People like Brian Ruff are really needed in both the public and private. So what is it that we've done from government side in terms of the private sector? We've invited them to become part and parcel of the quality learning centers that I was talking about, because we have to improve the quality in both the public and private so that they can be accredited, so that they can meet the standards, the quality standards that we want. We want them to go through the Office of Health Standards compliance certification so that they are certified that they can provide the services. And then after that, they must go through accreditation by the National Health Insurance Fund to say, are you fit to deliver the services that are required under national health insurance? That's why I'm saying that we should all be excited that this national health insurance is coming, because it's forcing us not only to improve the quality of health services in the public sector, but also in the private sector.
How is the private sector regulated, Professor Shisana? And I'm asking this purely on the basis of the exorbitant amounts that people are charged to get care in a private healthcare institution. It's expensive.
Well, in a sense, they are regulated through the medical schemes, because medical schemes is the one that defines what package of services should actually be delivered, for people. They are also regulated by the Health Professions Council, because all of those people that work in the private sector and the public sector have to be evaluated in terms of their performance. In case somebody reports a case to the Health Professions Council, then they take up the case and they do the investigation, and then they're able to determine whether the person can continue to function as a healthcare professional or not. Now, with the National Health Insurance, we are changing that. We are saying it's not just going to be the Health Professions Council or the Pharmacy Council or the Nursing Council that is going to do the evaluation. We are adding on top of that the Office of Health Standards Compliance, which checks as to whether the facility is able to meet the standards that are set. In addition to that, we say you have to be accredited, and there is a range of activities or range of deliverables that a provider has to have in order to be able to qualify to get funding from the National Health Insurance Fund. So we use funds as a means of controlling the quality of health services. If they do exceptionally well, they get a benefit, okay? They get a performance bonus if they do very well. If they don't do very well, of course, contract will not be renewed. This is a change. This is revolutionary. And I thought people would be very, very excited to say that now the government is getting it together insofar as the health system is concerned.
Yeah. Well, because you were one of the people that conceptualized this policy, the NHI policy, I want to take a break. When we return, I'd like for you to explain to us the rationale between those that are on medical aids or the continued existence of those that will want to keep medical aids when we have a national health insurance scheme that's supposed to look after everyone. We'll continue in a moment. You're watching News at Prime, and if you're just joining us, we are at the tail end of a conversation with the President's Special Advisor on Health Matters, Professor Olive Shisana, and we are discussing the National Health Insurance. Professor Shisana, before I get to why the continued existence of those that want to be on a medical aid when you have a scheme such as the National Health Insurance, we'll get to that in a minute. Can I bring up the issue of migration? And it really gets...
What?
Migration.
Okay.
It's a problem the world over. And South Africans really get hot under the collar. But it's the MECs, for example, of Limpopo, including the former premier of this province in Gauteng, David Makhura, who have complained in the past that our neighbors have their nationals come to South Africa either to give birth or any other medical emergency they may have. And yes, that is granted because South African law says if someone needs care medical emergency care. You must give them that. But now, the complaint by Popi Ramatuba, for example, who was there at the signing today, is that, but we're not compensated by your government coming into South Africa to a point where she even confronted a patient. How is that catered for in the National Health Insurance?
The National Health Insurance Act has got a section that deals with who qualifies to receive services under the National Health Insurance Fund, paid for by the National Health Insurance Fund. If you come in as a visitor from outside, you are supposed to come in with your own insurance, just like we all do when we travel to other countries overseas. We are required to bring in our own insurance so that we don't create a burden for the country where we are visiting. If you are a refugee, according to international regulations of the United Nations, you are supposed to get the same services as the people in the country. If you are undocumented, the Act requires that the Minister of Health and the Minister of Home Affairs come together to define a way in which those people that come from outside can receive services. Some of those people would possibly be economic refugees. Others would be political refugees. And sometimes it's difficult to make a distinction if you look at some of the countries that are surrounding us. If you are someone who's coming into the country and you are an asylum seeker, you'll get emergency services, because if you didn't do that, you would have people that have got, let's say, an infectious disease, and it starts spreading in the country. So your exclusion of those people from emergency services might actually hurt the country in the sense that your people might become infected.
Yeah.
So that is how the bill is dealing with this particular matter. It's not an open thing to say anyone can just come in and use the services in South Africa. There are defined categories of what services you can receive if you are coming in from outside.
All right. Very well explained. Thank you for that. Let's then come to the question about the continued existence of medical schemes whilst we have an all-encompassing National Health Insurance Scheme. What was the rationale behind that?
National Health Insurance is not going to cover 100% of everything. It's going to be comprehensive, but comprehensive doesn't mean that everything is included. So those services that are not included in the package of services to be delivered by National Health Insurance can still be funded by medical schemes. Medical schemes are not being abolished. Let's make it absolutely clear. We're not abolishing medical schemes. We're saying we're redefining what services they should provide vis-a-vis what the state is going to provide under the National Health Insurance Fund. So if you still want to have your medical scheme, sure, you'll have to make a contribution to the National Health Insurance, and you'll then have to make a contribution for those cosmetic services that you might need to have, or those services that are very expensive and cannot be provided through the National Health Insurance.
Which makes it...
And that still has to be defined, by the way, sorry. Yeah. That has to be defined in terms of what are the exclusions.
Which makes it prohibitively expensive. And in a way, you're forcing people to go onto the National Health Insurance. All right, final question. What did we model our NHI to? Is there a particular country where this was modeled on?
there are many countries. Croatia, for example, they've got a very well-functioning national health insurance. Kyrgyzstan have got a very good national health insurance. So there are many countries, particularly those that, started their national health insurance, recently.
NHS
So
in the UK, was that part of the?
We learned something from the British National Health Service. There are some good things about it, but there are also some different things. The challenge we have in the UK, as far as I understand it, is political. The political landscape is hurting the British National Health Service, which has been a really good model for many years, since it was introduced.
Yeah.
Now it's running into problems because of political issues. It becomes a political football. And I hope South Africa is not going to do the same thing as starting to have this political football of point scoring to say, yeah, I don't have national health insurance because of this. Let us look at what the people of South Africa need. They need health care, whether they have money or they don't have money. They don't have to wait for the end of the month before they see a doctor simply because they do not have money. They need to get to the doctor as soon as the need arises.
All right. Professor Olive Shisana, I have to tell you, I'm grateful for your time. Thank you so much.